But you guys are gonna be up here and it's just fine if you'd like to come up and sit either together or. And then we'll call the meeting to order if you just. And just FYI, I'm really glad everyone is dressed in their warmest clothes because there is no heat. A little schedule economized. Yeah, well, exactly. We are saving money. Okay.
Would you like me to create a little heat for you?
I'm sure there was plenty of heat to go around in this room. We want to attenuate that. So Aaron, let us know. Are we live? All right, we are live. So good morning, everyone. This is the Healthcare Reform Oversight Committee. And we're having a meeting to get an update from Green Mountain Care Board, Agency, Team and Services around some of the work that that's been going on, principally on Act 167, but then later this afternoon on the the payment reform system. So I'd like to just frame this a little bit because, pardon me?
Introduce yourself.
Oh, thank you.
Just in case someone doesn't know who you are.
Well, I think we should all introduce ourselves. Let's do that. And I'm going to start with Senator Westman.
I'm Rich Westman. I'm a senator from Lamoille.
I'm Jane Kitchell. I'm currently the chair of Senate Appropriations, and I am not running for re-election, so I'm in office till June. After 55 years, I'm hanging up my spurs.
I'm Representative Diane Lanfer, and I am joining the senator. I chair currently until January 7th, the House Appropriations Committee.
Ginny Lyons, Chair of Health and Welfare in the Senate, also currently chairing.
Lori Houghton, Chair of the House Healthcare Committee.
Emily Kornheiser, chair of House Ways and Means Committee.
Teresa Wood, Chair of House Human Services. James Cummings, I'm a survivor and I'm still chairing the Senate.
A couple survivors. So yes, well, I think what's really important to understand is that we have both money committees and policy committees around the table, and that we do work collaboratively in our legislative process. And I think that that's going to become a theme for me, is how can we continue to work collaboratively? And I would like to extend that thought into the room and to others who are online, that without any work together and collaboration together, we will not be able to accomplish the goals that we will be talking about today. I'm just I want to set a frame for this, and I'm going to set the frame in terms of collaboration and cooperation. We've seen a lot of discomfort in the media, and we've heard that there are folks who, are having their own little family disputes. Each family against another family. And that can't continue if our fragmented system is to come together and become a unified and consistent healthcare programs system of care for patients, for providers. We can't do that without working together. Elliot Fisher gave a great talk to the Green Mountain Care Board a bit ago, and one of the things that he said was reform is a process. And he derived that quote, reform is a process, from Bishop Tutu. Bishop Tutu happens to be someone who I've met and I've engaged with when I was a professor. But Bishop Tutu said, reconciliation is a process. It isn't simply an event. So I think we all keep that in mind. We are in the middle, or the beginning. We are actually in the beginning of a pretty significant process that we're going to hear about today. And I think it's each of us shares and has a responsibility, whether we're an organization or an individual. We have a responsibility for trying to reconciling some of the differences that exist and build a system of care for the state of Vermont. This isn't new. Our hospitals have been in in the red and had significant financial problems. Green Mountain Care Board's been working on this between 2005 and 21. We know that 181 rural hospitals were lost in the country. We don't want to lose rural hospitals in our state. We can't live without acute care. But we can transform that care in a way that we know where, by whom, how often, and when patients are cared for. Act 59 was a bill that was put forward that talked about sustainability, financial sustainability planning for hospitals, and that work continues. We hope will continue so that we see sustainability not just for the hospitals, but also for our insurance companies that are currently feeling stress, and all of us who are feeling stress in a system of real inflationary times. We're facing a time of increased utilization. We're facing a time of increased needs in substance use disorder, mental health, long-term care. We're looking at those things that we have in place that will help us survive. We've got some great programs. We have the SASH program that we may hear about later today when we talk about AHEAD. We have community-based systems that support care of individuals, either chronic or step-down care when they come out of an acute setting out of hospitals. But our system is fragmented. There's no question about it. And we have an opportunity today, beginning today, and it started in 2022, I think, with Act 167. We do have an opportunity to work together to build a cohesive, consistent system of care for folks, whether it's providers, insurance companies, institutions like FQHCs or hospitals or clinics, and most importantly, for patients. So I'm not going to talk anymore, but this, I think each one of us around the table and each one of us in this room could probably have said the same thing that I have just said.
Maybe not as well.
No, I don't know, probably better. But the point is, we are challenged right now in this state, as we have been for many years, and we are challenged now at the national level to ensure that we can continue to provide the care that's needed for people in the state of Vermont. So I will leave it there, and I will ask my vice chair if she'd like to.
I could not have said it better, but I'm going to be a little bit more direct on one piece of it, and that is that we need to put the politics aside. We need to put our egos aside. And we all need to come to the table and find a solution so that we are not a state that loses a rural hospital, an FQHC, or anything else that our Vermonters rely on to ensure that they have the care they need. So I hope that starts today.
Perfect. Could I just make one comment? As a senior citizen of the healthcare reform.
Of course you can.
I mean, I was around when we did the first healthcare reform waiver after when Howard Dean was governor. And that is, Vermont's not unique in this challenge. And so I hope that we can look at some of the efforts that are underway in other states, because this is something that the cost and access is really something that many of our colleagues in other states are struggling with, and including Massachusetts to our south, but also Oregon. And I have mentioned to the chair, Millbank has really been tracking Millbank Memorial Foundation or Fund. And so I think we can look to the future in terms of benefiting from those experiences and initiatives that are being undertaken as a lot of states are struggling with the very same challenges. And so if it's any consolation, this is not something that we have created that is unique to Vermont.
Thank you for that comment. I think that is really important. Any
So
of-
good luck, everyone.
We know where you live.
Exactly. Do you remember the old hospital data council?
Yes, I do.
Yes.
Yeah, well, I think we're really fortunate to have, the folks here today who can shed a light on the work that has happened and the work that's, going on. And why don't you, have you choreographed how you're going to present together? That's great. So, and I know that Brendan Krause cannot be here, which is unfortunate. Glad that you got here. So why don't you introduce yourselves for the record, and then we are all ears.
Good morning, everyone. I'm Jenny Samuelson, the Secretary for the Agency of Human Services. I'm excited to be here with my colleagues and with many of the providers who are in the audience to work together on this really challenging issue that faces us. And this morning, really, I'm hoping that you will see a level of collaboration between the agency, the Green Mountain Care Board, and the Department for Financial Regulation.
I'm Owen Foster. I'm the chair of the Green Mountain Care Board. I want to thank the committee for inviting us and allowing us to testify with our colleagues from DFR and the Agency of Human Services.
And I'm Emily Brown. I'm the Deputy Commissioner of Insurance at the Department of Financial Regulation. I've never been in this committee, but I recognize a lot of familiar faces, so thank you for having me.
Ready to go?
Go right ahead.
Okay.
All yours.
We got our slides. So a couple of my colleagues are in and are going to be helping us from the sideline. So our Deputy Director, Sarah Rosenblum from the Agency of Human Services is going to help run our slides. I think to get started, it's important for us to ground ourselves. And I've been in a lot of the education, housing, education, healthcare are three really huge emerging topics for us. And in education, one of the things that they've talked about is it's really been important to set the vision so that we're celebrating where we're trying to go versus all of the losses that we are experiencing, that we may have as we transform the system. And in this case, 2.5 years ago, we got providers together, and this was represented, Senator, in your comments. Where are we going? And I think for Vermont, we're really trying to get to what is the care that we need, so Vermonters can get the care when they need it, where they need it, and a price that they can afford. Easier said than done. That said, the easier said than done really relates to where we currently are at. You've spoken earlier about the challenges that we face. Both Chair Foster and I will go through a little bit of the data. But what we're really looking at here is that healthcare premiums have gone up significantly, rising dramatically over the last 5 to 10 years, and much faster than we've seen in other states, and at much faster than Vermonters can afford. They're also driving some of the affordability challenges that we're seeing in other sectors and sustainability within our own healthcare system. Vermont's hospitals are also experiencing significant loss, with more than half of our hospitals operating with margins that are in the red. Vermonters are experiencing long wait times for primary care and specialty care. There are gaps in our community care system, resulting in individuals having to seek care at the hospital when they could be seeking care in other spaces. And low-income Vermonters and those in rural areas are facing significant health disparities related to health-related social needs. Much of this is being driven by the demographics that we're experiencing in the state. Simultaneously, our population is aging, which, unlike the education system, we're seeing an increase in utilization and need. At the same time, we're losing significant workforce. And so I think that those are some key and grounding principles for us to really think about today. When we look at that, the Green Mountain Care Board has been approving premium increases based on the needs of our insurers and the utilization that far exceed those that we see in other states. As I said here on the left, as I said, Vermonters are experiencing significant access issues. And what you can see here are percentages of new patients scheduled to be seen within 14 days or between 31 and 90 days. That's pretty significant. So individuals aren't able to get in. When we looked at access studies in the past for things like endocrinology, cardiology, pulmonology, dermatology, real areas that are driving costs up and into our hospital system. As we move forward, what we see is that our hospital margins.
Question.
I'm so sorry.
No, that's please.
Why are all the Southern Vermont hospitals not,
We're just, for the sake of not including, trying to include 14 lines, we're including the 7 acute, or a grouping of the 14.
okay, and so the rest is in the gray? The
Yeah,
average?
the gray, it represents the average across all 14.
I'm so sorry to jump in when you.
No, please.
Can you state your name for the record? Sorry.
I'm sorry, I'm Sarah Rosenblum, the Deputy Director of Healthcare Reform.
Thank you.
Representative Kornheiser, I'd much rather this be a conversation back and forth.
We'll never let you finish though if we.
I've done this enough to know that.
So I'm sorry.
No, that's okay.
It's okay. Are you okay with questions coming up in the middle?
I think that charity,
Each one of you.
your discretion,
Okay,
and my preference is yes.
okay, good.
What we also can see, and I think Chair Foster will reinforce this, is that our hospitals are in a really challenging space as well, with more than half of our hospitals' margins in the red. This, it's a huge storm here where we say our hospitals, our premiums are going up, our hospitals in the red, and yet people still cannot, Vermonters still cannot get care. And I think the deputy commissioner is going to go through where we are in terms of our health insurers also being relatively precarious.
Thank you, Secretary. So as was mentioned, we're seeing stresses all throughout our healthcare system, including in the health insurance landscape. And for background, Vermont has one domestic health insurance company. It's Blue Cross Blue Shield Vermont. There are other participants in our market, MVP, Cigna, who also operate in what I'll call the state regulated market. But here we're talking about Blue Cross Blue Shield Vermont. We are the primary solvency regulator of this entity. So meaning that in addition to examinations that we do every 3 to 5 years, we receive quarterly reporting from Blue Cross Blue Shield Vermont of their financial status, as well as do kind of a year-end profile summary. And we're constantly in communication about, at this point on a bi-weekly basis, about what they're seeing, not only with claims, but then other aspects of the company's operation. And what this chart does is illustrate, since the pandemic, we've seen a claim surge or an increase in claims from a low in COVID of $307 PMPM. And what that means is the average cost of the per member per month that the insurance company is paying to cover a policyholder's claims. And then if we fast forward to where we are now in 2024, we're seeing $839 per member per month. And I know this chart doesn't illustrate it, but if you did look back pre-COVID, you would see a much more steady trend over time of around 5% increase. And what we're seeing, as you can see at the bottom, the 18, 13, 16, and 10% increases year over year. And while some of this has been reflected and covered through premium increases granted by the Green Mountain Care Board, the company has seen year over year losses due to underfunded premium, as well as what we're seeing now of unexpected claim experience, which is leading to month and year over year losses for the company. But we are aware of the issues. We're working very closely with Blue Cross. There is a plan in place to try to mitigate these losses and do what we can to work with the company, as well as our other agency partners, to try to figure out how to solve these issues.
I'm just wondering the extent to which legislation, in fact, has contributed to some of this. There's an insatiable desire to add more services to be covered. There was a bill that obviously the insurers were very concerned about, prior authorization, and in the end, something did pass. It was not as expansive. And then expanding under Medicaid and Dr. Dinosaur, taking the youngest and the healthiest out of that insurance market. So I'm just wondering to what extent we have to be careful about, we as legislators, who oftentimes are subject to a lot of advocacy to expand or to add services or whatever, might, with the best of intentions, actually be being somewhat a contributor to what we're experiencing, or perhaps it's too early to tell, but I think that there are collateral impacts with some of the made decisions, or with some of the proposals for spending or coverage that are going to be coming to the legislature in the next session.
Would you like me to respond to that or?
Well, maybe I'm just putting it out as
Yeah.
something to be very cautious about as we are considering some of these requests. Because they do have an impact, and they say, well, it's rather modest, but there's an accumulation of somewhat not modest. So it's just more of a caution, I guess. I don't expect you to respond to that. It's more sort of something for.
It has,
Come back.
it's a comment to us as well as to folks at the end of the table
Yes, it
and
is.
what we'll be facing legislative. If you do have a comment to make on Senator Kitchell's comment, that's helpful.
I would just say, I think that is definitely a part of it, but it's not the only
Well, I
factor,
don't,
right?
no,
And-
I would not suggest that at all.
Yeah, and I think that when we are making decisions, it's important not just to focus on one part of the market, but to really understand how those decisions can then have a ripple effect through other aspects of the insurance
That's my
market.
point.
Yeah, yeah.
A quick question, and this is partly because I can't see the small print.
Yeah.
So for this information going from 307 to over 800, I know Blue Cross Blue Shield has the QHPs, they have self-insured, they have Medicare Advantage. So is this across the whole, all their covered lives?
Yes, correct. That's a really good point and something I should have mentioned. So this is across all lines of business. If you look, there's a little asterisk at the bottom, and it says excludes Blue Card, FEP, and Medicare primary insured claims basis. So Blue Card, for everyone's knowledge, are claims that are paid outside of their Vermont network. So the way Blues plans work is that you have your Vermont network, but then you have a Blue Card program, which if you live in California or another state with a Blue plan, you can access that plan's network. So when it says Blue Card, that's what that's referring to, and that is excluded. FEP are federal employee plans, so that's also excluded. And then Medicare primary. So obviously that's not part of this analysis because those rates and reimbursements rates are out of control, or out of the control of Blue Cross Blue Shield.
That's Medicare Advantage is part of it.
Correct. And Sarah Teach Out is an audience, but I believe it's excluded.
Thank you.
Or included, I'm sorry. Yep, so before we move on, I think I could talk about a few of the drivers. And it is early times. I think we're still trying to understand fully what is driving the high PMPM that we're seeing in 2024. I think there are some changes that Blue Cross is seeing in the level of outpatient care, as well as the reimbursement rate that they're paying for that care. And then as well as prescription drug costs, which are driving a lot of the increases. And that isn't only in the price of drugs, but it's specific drugs being utilized that may be more expensive. And while very few individuals might be using those drugs, because of the high cost, it can have an outsized impact on the overall cost of care that they're providing.
I think it's important we didn't put the slides because it's really early for us to note this. But we are also seeing some similar drivers in this year in terms of our overall utilization and Medicaid going up significantly. And so we're in the process of analyzing that. Some initial indications are some additional increases in inpatient hospitals, but it's too early for us really to determine the impact of some of the other effects. But I think what we're hearing from all of the insurers and from providers is a significant increase in acuity, somewhat driven by delayed care and other factors that feel a little out of their control. In addition to that, and as we look at the next slide, it's also being driven significantly by our demographics. And our demographics have an impact on two things. First, we're seeing a reduction in the overall number of individuals who are currently in the workforce, which is causing significant pressures across all of all of the sectors in our system, but is impacting the healthcare system in a pretty pronounced way because they're bringing in travelers and others. While that's stabilizing, there is significant cost impact. The second impact is an increase in the number of individuals who are seeking care as they age. And the third really is, and not the only other one, but really is pulling fewer and fewer people who are in our commercial marketplace, making it so that there is less ability to spread the risk across a broader group of stakeholders. Before I move on, any other things? Chair Foster, and I know you're going to go through some additional ones as well.
You want me to do that now? We are coordinated, but not perfectly coordinated.
HS will take responsibility for that. Our slides were done very late.
No worries. It is fine.
The secretary and I have been in a lot of meetings and negotiations last week, so we perfectly. So I just want to give a little background and further context to what the secretary was speaking to. And what the chair spoke to in the beginning, which is this process that we're in now has been going on for quite a long time. 5 or 6 years now, we've been building towards this moment. And my point here is the moment is now. We are in a really difficult time in our healthcare system, and we have been preparing to make the kinds of decisions and change the policies that we need to change so that we have a sustainable healthcare system. My view as the chair of the board for the last couple of years now, since October 22, is there is an opportunity to think better about the whole system as a system. I do think that sometimes we get a little bit siloed in our thinking. The care board is focused on hospitals and one component of insurers. And, AHS is very focused on VAs, and there's a whole web, but sometimes we get a little bit siloed. And I think I'm guilty of that sometimes too. I know we are at the board, and we're trying to really focus on that. So the point here is that the board, the legislature, the agency have all been working on and thinking about the concern because the storm clouds were on the horizon since at least 2019. And the slide is just to provide some history of all the work that everyone's done to get us to this point. Next slide. I believe Senator Kitchell spoke to that this is a national problem, and it sure is. That this of rural healthcare and rural hospitals is a very, very difficult business. And it is a business. They have to pay their bills. They have to see the patients. They have to pay the providers. This is a chart of all the rural hospital closures since 2005. There's been 150 closures since 2010, and we're seeing them, frankly, more and more every single year. We just saw a number of closures in Massachusetts, and Massachusetts is a very wealthy state, frankly, compared to Vermont, with a really great healthcare system, and they're experiencing this too. We also saw last year have very large reductions in force. I think they reduced 175-ish positions. A lot of those were open seats, but they had to do some extreme cost-cutting measures. And just this last year, we also saw, just recently, the UVM Health Network had to make some really tough decisions too. And there's a lot of media and all of that goes on, but this is happening everywhere. And it's a problem that we need to confront and not think about in terms of blame or, it's just a problem we have that everyone has. This chart does not indicate all the service line changes that happened at these hospitals. This is just closures. It's not actually that you have to reduce service lines to stay solvent. And that's an important distinction. I will note a highlight that I think sometimes gets lost. We have not lost a hospital in Vermont. That is a remarkable accomplishment. And I think it's something we should actually all be proud of. But it's come at a cost. It's exceedingly difficult for the state to do that. Hospitals have worked immensely hard to make sure that's the case. The legislature, care board, agency, DFR, everybody. One component to continuing our hospital operations as they've been has been financial. There's been immense financial contribution to make sure we don't lose hospitals. This chart speaks to that. I'll go a little bit slowly because there's a lot of lines, but the bar graph is how much money in NPR, the revenue at our hospital systems in Vermont. Okay, so that shows you the growth of commitment of dollars to support our hospital system, all payer, Medicare, Medicaid, and commercial. And then the green line is what the all-payer model growth range was, the target, our goal in the all-payer model. The high-end goal was a 4.3% annual growth rate. We are far beyond that. And that's not to say it's a good thing or it's a bad thing. I'm saying it's a lot of money and that it gets more and more difficult to continue to exceed that. The goal in Act 48 was to contain healthcare costs to what we can afford. That's just logical, it's rational, it's necessary. We have been going far beyond that, and that is a concern as we continue to go forward. The orange line represents the lower level of the all-payer model goal, 3.5% goal. And then the bottom blue one is a consumer price index for an inflationary measure, PCE. And in the right box, you can see that at the lower all-payer model goal, we have spent about $483 million more in hospital revenue than we had targeted in the all-payer model. And at the higher level of that all-payer model goal, we've spent $278 million above the higher level. And as to PCE, it's considerably more. Thinking about the healthcare system as a system, we need to think about what happens with this money. In my mind, there's four constituents to healthcare dollars. There's the people who pay it. There's the hospitals that need it to fund their operations. There's the FQHCs. There's the mental health providers. There's the independents. There's long-term care. Every dollar you take from one place has an impact somewhere else, unless you can come up with more dollars. So if UVM has a reduction, that is going to hurt UVM. It plainly will. Anytime you give less money, it's more difficult. But when you give more money, it's more difficult elsewhere, at the insurer, at the FQHC. And so my point here is that we really need to think about our allocation. We have some of the highest healthcare costs in the country, and they're going up about as fast, if not faster, than any other state in the country. So how do we think about our allocation? That's the key here. How are we going to use these dollars in the most optimized way for our population's health? And that's very important, I think, as we go forward in all these discussions that we're having today. This overlaps a little bit with the secretary's slides. This is a graph of the days cash on hand at the Vermont hospital system. So while we have not lost a hospital, and we should all be very proud of that, we are seeing a deterioration in their financial health. This line represents the decline in the days cash on hand. That's a very basic measure of hospital financial health. You really want it over 100 days cash on hand for a hospital. Ideally, I think you really want it more 150 to 180. More is not always better. You need to be investing the money and using the money, but 150 to 180 is kind of a comfortable range, I would say. So despite all the significant financial investment that we spoke about earlier, we are seeing nonetheless a pretty significant decline. And if we're going to abate that decline, we either need to abate the expense growth or we need to contribute more money. And I don't know that more money through increased Medicaid spending or increased taxes is a particularly viable option for the populace right now. I know that ratepayers don't have that tolerance right now, and they don't have that money to spend. And hopefully we're able to get more money from the feds, but the feds aren't always looking to give you more money either. So there's some realities there that I think we need to think about in terms of all three sets of payers. It's just not a place to go where we can tap the financial resources we need for the problems that we have. So the legislature, and we'll speak about this a lot more, allocated significant dollars to the Green Mountain Care Board to conduct a study on the system. It's called the Oliver Wyman Report. It's an independent report. And Oliver Wyman raised some alarming concerns, and they used some alarming language about those concerns, about risk of hospital closure and what the financials look like. The secretary spoke to the demographics, and those are really, really critical to focus on. We're not going to solve it here. We're not going to solve it this year, but it's something we must work towards. The reason for that is there are so many problems with demographics in healthcare. As people age, they retire. We're losing physicians, we're losing nurses. The other issue is they need more healthcare and more expensive healthcare. And the third issue is that they pay less for healthcare because they go into Medicare, and Medicare does not pay as well as commercial. So you can see all three of those things really confounding our healthcare system. The demographic projections that the state has are not favorable. As healthcare costs rise, it hurts demographics. it is hard to recruit people to come and stay in Vermont when they're young and paying a very significant premium for healthcare. Likewise, if you don't have an adequate system, you can't get a doctor, or you don't have a strong hospital in your community, it's also hard to recruit and retain families, right? If you lose a birthing center or an academic medical center services or whatever it might be, it will hurt your ability to attract business. But you also can't have it crazy expensive, as we all well know. So Oliver Wyman predicted is the right word, or raised alarm that we will be losing hospitals in the coming years, potentially, if we do not take action. I think they classified 4 hospitals at significant risk financially. And they said that I believe all hospitals, or all but 1 or 2, will have long-term serious risks.
Question, about the report, there seems to be dueling data, or we're questioning the data. And we get that often, but regardless of that, the fundamentals, the fiscal fundamentals, are they debatable?
I do not think so. I mean, if anyone wants to agree that there's no need for more than 3 or 4 or 5% revenue increase and they'll be solvent, I would agree to that. I don't think that's the case.
I mean, because obviously there's been so much attention and focus, and we don't agree with this particular finding or this data we don't agree with, and so that can distract. But my question is, does that change the fiscal fundamentals? And the answer is no. Okay.
Yeah, I think, Senator Kitchell, if I may, there's a lot of, I often talk about it as data grief. When we put data out there, folks,
Well, we call it dueling data.
exactly. But I think whether we agree on every part of the data that exists, it is somewhat irrelevant, because the direction that the data is going, everyone can agree on. The degree to the problem, maybe not as much, but the fact that we have a problem is indisputable. And I think that goes to the fragility of the systems, not just the hospitals, but the federally qualified health centers are facing challenges. Our substance use providers are facing challenges. Our designated agencies are having difficulty staffing up and facing challenges.
We're very familiar with that.
Exactly. And so I think what's not disputable is the fragility of the system, and that Vermonters can't continue to afford the premiums that they are paying, or that our health insurers are in a healthy space, because we know that they're not. I think the biggest challenge that we have is trying to agree on what it is that we want to do about it. So I think everyone can identify that there's a problem. It's a matter of rolling up our sleeves and identifying what each party's part is in actually creating a solution.
I'll just add to that. I think that's a really good point to be made, that the Oliver Wyman report did identify problems, including workforce, transportation in rural areas, and all of those things that we in this building have been aware that they're there. But now we have a set of problems together, and perhaps a solution that works toward all of them instead of individual.
And I think what you'll see throughout today is that as we look at the Oliver Wyman report, it does give us a set of vast recommendations that we still need to assess what the feasibility of them are, what the impacts are for our communities and for access to care, and what the costs are for each of those different items, and which ones will meet our needs, short, medium, and long term. And that work is currently ongoing. I think the Oliver Wyman report, we spent a lot of time focusing on the hospital recommendations, but there's a significant amount of recommendations in there that are in alignment with the direction that our partnership with the legislature and providers has been going for years. And we'll touch on that in a little bit, but related to shoring up the other systems. And I really want to thank the legislature and others for really focusing on the fundamentals over the last couple of years, as we've been waiting for the Oliver Wyman report and really shoring up those systems. As Chair Foster said, we can't just focus on one area. We don't have the convenience to do that at this point. We need to take a multifaceted approach.
And it's important, as you all well know, that these things are really interconnected. If you lose an FQHC, or they have to cut services, it backs the hospital, it hurts the hospital's finances. And if you lose mental health, it just hurts everywhere. So you really have to, I think we're in a state where we need to make sure we're not losing any services anywhere because it does have a ripple effect. This is actually just from the Becker's, it's a healthcare publication. This came out a couple weeks ago, Friday, November 22nd, and there's a study done on rural hospitals. So your question is, there's disagreement about the data. I think it would be incredible if Vermont doesn't have rural healthcare financial problems. We'd be the only state in the nation, and that's just not the case. The Becker's reported on this study, and they found that Vermont had 8 hospitals at risk of closing, 4 at immediate risk of closing in the next 2 to 3 years. This aligns very closely with what Oliver Wyman had projected. I think we would be delusional to think that we don't have serious financial issues across our system. And that's why we're here. So the next slide, I did want to speak to the community health centers and some of the other providers in the system. We do focus a lot on the hospitals, and I do think it's important to think about everyone else as well. Not that they're ignored by any stretch, but sometimes I don't highlight where they are. So I want to thank some of the FQHCs, the independents, and others for collaborating with me and working with me to get some of their data to bring this forward today. This is a slide from Community Health Centers of Burlington, and this is their days cash on hand. It's from 2021 to 2024. And again, you can see it went from about a high of 145 days down to 62 days, which is a precipitous decline, and it's continuing to decline on perhaps an even accelerated basis as what this represents. The next slide is the Community Health Centers of Burlington operating margin, their losses. So in 2018, they were positive. They made about $1 million. That has declined to a projected 25 loss of $2.3 million. 60-ish days cash on hand, they cannot survive at a $2.3 million loss every year or in the future. They had about a $655,000 loss in 2024. So in the 2 years, they'll lose about $3 million.
So what's the story behind that? Is it the change of the payer mix? Is it increased utilization? Is it having to pay contracted nurses? Obviously, that's very precipitous. So they must obviously have a sense of what the revenues versus expenses look like.
Yeah, it's multifaceted, as these are with any organization. And I'm not an expert in their finances, but what I can tell you, and I have in a couple other slides, is one of the biggest drivers is their healthcare costs.
Oh, that's what the UVM stands like.
Sounds like property taxes.
I'll show you a slide on it. Their premiums have spiked dramatically. So their prices for their staff has certainly gone up. Their nurses' salaries have gone up, which is wonderful and appropriate and necessary, but that's a cost. And then their health premiums have gone up, I believe it's around over 60% in 5 years.
I wouldn't be surprised.
So the healthcare costs, and the cruelest of ironies, is hurting the solvency of our healthcare providers. The next slide is Little Rivers, another incredibly important FQHC in rural Vermont. And you see this blue line going up, but that is up to a continued negative margin. They lost around $2 million in fiscal year 22, and in 23, they are still not breaking even. Organizations of this size cannot survive with these kinds of losses. On the next slide, this is Little Rivers days cash on hand. It is around a week.
That months, what is the
Days.
oh,
5 days.
days?
So every bad month you have, when this is
my
your days
district.
cash on hand, creates a risk that you need to close or you need to cut services. I also spoke with the Howard Center, similar.
Yeah.
And the Howard Center's commercial insurance costs have gone up over 100%. I believe this last 5 years, it could be 6. So a near doubling of their premium costs. And they are around single-digit days cash on hand as well. The Howard Center, as we all know, treats our most vulnerable, and it's incredibly important to the system. If you,
We have a question.
Go ahead. So the folks that you just talked about, large, to a large degree, depend upon Medicaid. in terms of the folks that they serve. And I guess one of my questions is, we certainly haven't seen Medicaid rates rise to the degree that healthcare costs have risen. So that would seem to be particularly for folks like this and for the designated agencies and even for hospitals, I would imagine, part of the issue.
So we started to dig into this a little bit, that specific question about Medicaid rates, and I'd want to do a little bit more confirming. But when we looked at it for federally qualified health centers, it wasn't the case that Medicaid was the lowest payer. In fact, we weren't at all. And so I think in having conversations with a couple of the FQHCs, because they come to the agency, on making us aware of their challenges, you know, and there are really 3 FQHCs and who have come forward with pretty dire straits, North Star, Lamoille, and CHD. With North Star and Lamoille, part of it is also looking at structurally what's necessary to keep them moving forward. In both cases, they've identified pretty big practice footprints that they're not able to fully staff at this point in time. And so they're not able to optimize the revenue that's necessary to keep the current footprint that they have. I think that's similar to what we heard from UVM Health Network, where they had practices that were within 8 to 10 miles apart. The same thing with Lamoille, the same thing with North Star. They're not fully staffed enough. And their overhead costs for those facilities was challenging. It's not the only solution, but I think what it identifies some key structural issues that we're going to see across the sets of providers that we're going to have to look at and address. And in several of those cases, we're seeing consolidation of practices. We saw that with North Star. We saw that with UVM in order to be able to afford their footprint. So I don't think it's as simple as saying that it's a Medicaid rate issue only. I can say that DEVA and Commissioner Groves is here. We can talk about it in more detail at another time, but DEVA is working very closely with the FQHCs to look at things like changes in scope and rates, and what we need to do for extraordinary financial relief.
Yeah, and I wasn't meaning to imply that it was the, an only situation, but we've been talking about the expense side of things and certainly on the revenue side of things. And we know in this building, particularly because we deal with the Medicaid rates a lot, that the revenue side for Medicaid rates really has not kept.
And that's why I was surprised to find that that Medicaid for FQHC wasn't the only. And I think we'll talk a little bit later about reference-based pricing. And one of the things that Medicaid did a number of years ago is that when they were looking at their rates, they pegged many of them to Medicare, and they made decisions about where they would ensure that their rates are in some cases higher than Medicare. And this is an example of one, but it's not just we're not just above the Medicare rates for primary care. So I think it's a really good question, Representative Wood, and something that we should dig into and that we're committed to getting into with the federally qualified health centers. But it's more complex than just a Medicaid rate issue.
I would say, though, that probably out of the whole delivery system, our mental health, our community mental health is predominantly Medicaid, well over 98%. So what we do in terms of reimbursement is very much, and there's not any kind of fair mix or cost shifting. And so what do we give, 3% last year?
Yeah, it makes a difference what we do or don't do.
Yeah, regardless of either of all of these providers, Medicaid, particularly for our safety net providers like our FQHCs and our designated agencies, Medicaid is a significant portion. And so we do have an impact or an influence on that. So I don't want to discount that, but I just want to make sure that we were aware that it's a lot more complicated. And that regardless of what we do, similar to education system, we're going to, across the system, need to look at structural changes. And yet primary care is foundational to the care that we provide.
I believe Howard Center is about 90%. government payer.
Yeah,
Medicaid,
Medicaid.
yeah.
So-
All the designated.
So if you lose, if their expenses go up 5%, their healthcare costs go up 105 years and it's 0% increase or 3%, it's a financial problem. And all these, it's not just more money and in every system, what's happening with the expenses? Are the expenses reasonable? Are they appropriate? And if they are, we gotta fund them. Relatedly, on the commercial side, of course, an FQHC gets commercial money, independents get commercial money, independent primary care. One thing we have been focusing on at the board is what are the rate increases they are getting in those spaces? To me, it's important that we put our money where our mouths are. We talk for years about supporting preventative care, mental health care, primary care. Is the money following that? I don't think it is. So even within the systems or really at large, that's one of the things the board has worked on the last 4 years, 3 years.
Yeah, but defining it, capturing it, and redirecting it is a challenge.
It's incredible. Like it's why do we have it frustrates me no end. But what we have seen some equilibrium come into the commercial marketplace. In the last year, we saw closer rate increases that were more around inflation for both hospitals and non-hospitals in the private market, which I think is beneficial to this point of sustaining the entirety of the market. But again, that is difficult. Next slide, Sarah. I'm going to stay on this one just for a second. I don't want to take up too much time, but there's an incredibly important piece in this that might not be obvious at first. One, this is just a chart of the annual premiums for a family of 4 on Blue Cross, probably similar on MVP or anyone else, but QHPs. It's over $40,000 in premiums for a platinum plan in 2024. And it had a large double-digit increase for 2025. I'll be shocked if there isn't a large double-digit increase again in 2026. We can't keep having double-digit increases, period. The silver plans are quite a bit less, but nonetheless, $35,000 or so is not affordable. And the premiums are really significant. Keep in mind, a lot of families like mine have chronic disease. You need to be on a platinum plan if you have that kind of situation. So you don't get to choose and save money. You have to have it. The point here that I think is potentially a little hidden that is really important for all of us to think about is that the subsidies for the individual plans are set to sunset in 2025. That will have an enormous impact on the healthcare system if it were to happen, and most importantly, on those people who rely on them to buy healthcare. If they do sunset, there will be a segment of the market, I would predict a fairly large segment, that will not have health insurance. That creates medical debt for families. It creates delayed care. It creates more chronic disease. And it also hurts the finances of the entire health system. And so people transfer from commercial insurance payers, the very best, to some segment of them will be paying less or bad debt. That hurts everyone's finances. We do not know the outcome of what will happen with those subsidies. It's not a red issue or a blue issue. Both red and blue. There are many people that need the subsidies. So I don't know what will happen. I'm just raising it as a potential issue. That's always been there, but I think there has been an administration change. I'm not sure if it's clear which direction the administration is leaning. I have no idea.
I'm sorry, can I just add something there? So I recently read, and I apologize, I don't remember where it was. There was analysis done on the effect nationally if we lose these subsidies. And I mean, we're talking thousands of dollars a month. So I'm glad you brought this up because I think we need to be talking about it more. It is thousands of dollars a month that people will be paying just for a premium, more than they are now, just for the premium, and still have a very high deductible plan to have to cover.
And that's before another increase for 25 and potentially a very large increase in 26. The other issue is our QHP increases. There is a whole segment of commercial insurance, right? It's not just QHPs, but directionally what you're seeing in the QHP plans is consistent with what you're seeing in the ASO market.
And ASO is?
Administrative services only, the non-QHP plans. So for example, Howard Center is administrative services only contract, and their premiums have actually gone up more than the QHPs. Others have gone down less. There's risk pooling in there, so it's a little complex. But directionally, those aren't like 2% and these are 15. They're like 15 and 12 or 15. It's very, very high. So to Representative Houghton's point, if the rate goes up again and you lose any piece of subsidies, you're talking gargantuan sums of money for Vermonters to get health insurance. And they won't be able to afford it. There's all kinds of collateral consequences to this. My little brother is a carpenter. He works with a lot of carpenters. A lot of carpenters aren't working a full year because they want to get the subsidies. We lose tradespeople. My friend carpenter just moved to Florida. Taxes. Very wonderful community member, a great friend, and he left because healthcare costs and taxes.
So I'm looking at our time and what we need to cover.
I want to talk more about Michael.
Where we are with 167.
Well, why
That'd be helpful.
well, I don't want you to skip over anything. We can go a little bit into our lunch hour when we get there. But if we could finish, the information that you wanted to provide, and we'll try to hold the conversation at this point until later.
I've made all the points I wanted to make. The only one I would emphasize is that the situation of the insurer, there's a statement from Ken Frost in this, and the financial position is very difficult.
Next slide.
I think it's 2 or 3.
One of them.
The committee
Yeah.
can read it at your leisure, but the point is that claim surge that we spoke about earlier, they're losing more money every month on their business. The large rate increases the Care Board has been approving and that people have been paying is not enough to cover the claims. So we're giving huge increases and the claims are more. And if they're more, that depletes the reserves. Think of it as their days cash on hand. And that is going down precipitously to levels that are very, very concerning to the Care Board.
That should improve somebody's bottom line. But who's?
So are you ready for Act 167 updates? And we have the other slides that you've given us. I'm going to encourage us to read through, and I see that this slide is a slide that I handed out separately, and it probably is going to.
And that side we'll come back to, I promise.
Okay.
Fine. As we go through our, just a quick reminder about, the portions of Act 167 that we're going to talk about today. We're looking at the 3 sections of Act 167. The first one was to propose a federal model, that is a multi-payer payment model. The second, underneath that, is to design a global budget model. The third was stakeholder engagement process, and you've heard us already talk a little bit about that this morning through the contractor's name who facilitated that, Oliver Wyman. And the fourth is, where are we going to go following the Oliver Wyman report? So I'm going to breeze through these to help us try to catch up a little bit on time in terms of where we are. But just as a reminder for the multi-payer payment model, we really were looking, the legislature asked the Agency of Human Services in collaboration with the Green Mountain Care Board to look at a model that included a total cost of care, global budgets, strategies for investing in this broader continuum of care that we've been talking about, reducing healthcare inequities and investments in social determinants of health, and deciding where we would go with the decision for the ACO and whether the next model would include an accountable care organization. Act 167, through Act 167, the work that we've undertaken, and we've talked about where we were legislatively, but just to give us grounding, the agency has embarked in several different practices. One was to initially stabilize the healthcare system, which helped inform some of the work under Act 167 for the payment models. The second was to engage in a process of trying to decide which model we should go into next, and to work with the Green Mountain Care Board on the stakeholder engagement. And the third really now is to decide whether we're going to go into another federal model and which one we're going to go into. What we assessed several different federal models to see whether they matched what Vermonters' needs were, and we did this working in collaboration with providers, the Green Mountain Care Board, and the insurers through the Healthcare Reform Work Group. We looked at programs like ACO Reach, making care primary, and then provider-specific payment models. We also did some preliminary assessments very early on reference-based pricing and returning to fee-for-service. And so we'll touch on some of that at the end, but we won't spend a lot of time on that today. Happy to come back and to discuss that. There were a few key findings in terms of the alternative payment models, which we'll discuss in more detail at the end. But there was the first one is that no one model accomplished everything that we were trying to do or addressed all of the challenges in the healthcare system. And I want to reinforce that. It doesn't matter what model we go with, it's not going to solve every part. The second is that if we're going to participate with the federal government, we may need to pair and mix and match models. Those of you who've heard me in the community, you'll often hear me say, we can have 0 models with the federal government or 7 models, but they're not going to offer us one model. We tried. We spent 2 years negotiating with them to try to create a more comprehensive model. And that's how we got to a head and a head potentially matching what Vermont wanted, which was a lot of discussion back and forth with them. But they made it very clear, 0 models or 7 models, no one model. And so that left us with the potential for trying to pair models together. And, we talked this morning about the fact that we needed to take a comprehensive view. And that's what we were trying to do when we were negotiating with Medicare. At this point, it's the more than one mixing, matching of models. The 2 that have really emerged, you've already heard us in other forums talk about implementing CCBHCs, which is the model for mental health clinics, and the HEAD model. The goal here would be to make sure that when we negotiate those models, that we are looking at priorities so that, because we as a state cannot afford what we've done in our last model, which is allow all flowers to bloom. Given everything that we've outlined this morning, we need to be incredibly focused. And the group that was doing the healthcare reform work through the healthcare reform work group at the end of the pandemic, when we started the stability work, really had identified some key focus areas. And we've talked about them this morning. Substance use, mental health, long-term care, and home health supports in our communities, all with a focus. And then in the parking lot were primary care and transportation. The interesting thing is those emerged in the Oliver Wyman report as well. As we think about that was really targeted at keeping people from the highest levels of care, reducing the number of boarders in our emergency departments and reducing the number of people going to emergency boarders in our inpatient and reducing the number of people going for inappropriate care to our emergency departments. And so again, mixing and matching models with a set of clear priorities of what we want to choose because we don't have the workforce or the bandwidth to do everything. And in this case, we would create incentives, shared incentives between those models based on a set of shared measures and a set of incentive payments. I want to point out that as we looked at models, it doesn't matter whether we're talking about the HEAD model, reference-based pricing, or fee for service, or who knows what's going to come next, but the federal government is very slow at emerging models. There were some inherent risks. Do we have the resources to implement the model? What are the impact on commercial affordability, which we've talked about? What's the impact on access to services? And what's the sustainability of how does it impact the sustainability of our healthcare providers? While we were doing that work, you've heard me talk a little bit about our sustainability efforts. We need to take the agency as a whole, because we are a regulator in many of these spaces, it is our responsibility to look across the system to make sure that we've got that we're meeting not just Medicaid recipients needs, but the broader population health needs. We didn't pause while we're waiting for the Oliver Wyman report. And so I do want to give us some hope after the last portion of what we talked about. Vermont is doing a lot in the areas that are broadly around the system. In partnership with legislators and providers over the last couple of years, following the recommendations that came out of the sustainability work, which align with the Oliver Wyman work, we have implemented elements in the mental health space, including things like 988, mobile crisis, and mental health urgent care, stabilizing providers in that space, adding capacity for youth mental health. And that the result of that are less individuals who are going to our emergency rooms, and they're staying there. They're staying for a much shorter period of time if they do. With our skilled nursing facilities, we identified that we've compressed our skilled nursing facilities almost too much. And we were losing skilled nursing facilities. As we see our demographics change, we don't have enough skilled nursing facilities necessarily to meet the demands. And the demands have changed over time. The individuals are now aging with substance use, mental health, and behavior issues and criminal behaviors that make it difficult for a skilled nursing facility to admit individuals, and they were staying there. We've been able to implement a long-term care facility. These are the types of structural changes that we are going to need to do going forward, both identifying investments and identifying changes. I'm not going to go through the rest of the list, but substance use disorder is one of them. We haven't been successful in this area, but we've done a lot of things. And we're doing a gaps assessment. So I look forward to this next session in partnership with legislators to really talk about how we fill some of those gaps over the next few years. Hospitals post-pandemic, we provided additional dish payments that got us to where we are, but it's not ever going to solve the problem. And we sunsetted home health, the provider tax, and with primary care providers embedding mental health. So there's a lot of work and a lot of infrastructure to do this that's multifaceted and multidimensional. And I bring that up today because I think it's really important in looking what you asked us all to do back in the requirements for Act 167. When you asked us for payment models, those payment models cannot be restricted to just something like a head. They have to be much broader and they have to cover the full continuum. And here are some examples of that. In Act 167, in terms of the payment models, you asked us to look for here are some of the elements at the federal level. And I just want to match up on the left-hand side, what you see are the requirements in Act 167. And on the right-hand side, and we'll cover this in more detail when we walk through AHEAD, what are the key elements of the AHEAD program. So we're talking about trying to control the total cost of care so that, as Chair Foster said, we can begin to make investments, moving things through in different areas of our system based on what our priorities are. We're looking at global budgets so we have the flexibility, predictability to be able to change our system, and we'll go through those later. Specific targets and strategies for increasing primary care. So enhancing the amount of money that goes to primary care to address some of the issues that we were talking about. In the Medicare, we're talking about putting in as much as $15 to $21 to primary care per person per month. We'll go through that in more detail, but also being able to take investments and put them into the other areas. And then strategies for both planning and investments in health equity. So we will go through, I wanted to make sure that as we went through Act 167, we did it in sequence, but we'll go through the details of the AHEAD and what we model and what we've negotiated. It's not a slam dunk. We still need to assess whether we're going to do it or not, but at least it gives you a clear sense of the process of how we got here. As part of that, we've been working closely with the Group Care Board on identifying what a hospital global budget model is. The flexibilities in the hospital global budget model provide us with the opportunity to allow the hospitals to potentially transform while being able to continue to be sustainable. But I'll let Chair Foster go through the two of the elements, which is the stakeholder engagement and the hospital global budget that we've been working on collaboratively together.
Sure, thank you. As with the 167 transformation work that was part of this bill, we also had an extensive engagement process with the hospitals, the HCA, insurers, a number of providers on developing a model hospital global budget. You got to keep in mind there's Medicare, there's Medicaid, there's commercial. And one of the shortcomings, I think, ultimately of the all-payer model was that we were able to contain costs for Medicare, but I query how valuable that is to us as a state. And we need to be mindful of, is it sort of, Member Holmes uses this analogy of squeezing on a balloon. Did you squeeze here and blow out over here? And our commercial costs have not had the same reaction to the all-payer model that we had hoped, expected. And so we need to think about the AHEAD model in connection with all payer and will it work? Keep in mind, a global budget is a cap, and Care Board has revenue caps and the global budget is a revenue cap. And when the board has capped revenue, there are concerns that you need to make changes, not enough money. And so if you cap Medicare, you need to make sure you're watching what happens on Medicaid and commercial as well. This is a tiered process. We have only so much money to do each process and only so many resources, only so much bandwidth amongst all of us to do in the hospitals and everyone else to do the work. I don't have the numbers of the stakeholder meetings. They were weekly, bi-weekly. They were numerous, constant. The board last summer in July submitted a draft global budget methodology to the feds. That's available. It's public. It's not signed off. It's not something that's approved. One of the issues is it's incredibly complex. I think the draft I read the other night is like 65 pages, and any one of those points has a gazillion points underneath it. And we talk about predictability, and we don't know what's going to happen in the healthcare system, and we don't know what happens when we take certain policy directives, as I think Senator Kitchell was alluding to. The best of intentions, but all of a sudden something else happens as a consequence. So working through all those things is something that the secretary and I and our teams are working through really hard right now. We're in a very, it's been a fluid environment because there's been some administration changes, some delay on the Fed side here, some acceleration there, and that creates a lot of work to get through it all. So the global budget methodology has been proposed. There is also a draft methodology from the feds that I'll call off the shelf. It's just their model. You have an option of doing the feds model, or you can try and customize your own. And through Act 167, the state allocated funds to the board or for the AHS to come up with our own customized model. And that's the draft that's been submitted. The board has not voted on that draft. We're continuing to work on it. Should the parties all elect to go forward with the model, that draft could change, or we could take off the shelf, or we could do something in between. One question is operationalizing it. Can you operationalize it? Like, do you have the people? Do you have the resources? Do you have the knowledge? How many people does it take to run a global budget? It's very complex. It's also a more intrusive regulatory environment. You're now looking at reviewing service line changes and additions. It's almost like CON for service lines, right? So it's a different model. Or can we do it a different way so it's not so burdensome? I think that's about where we are. We are working on it every single day. I got an email from the secretary at 6 something this morning about it.
Why you didn't get the slides?
Anyway, the stakeholder process has really informed this customized model that we have. There's a lot of pros to it. One thing that I like is it does have that methodology in place that helps you protect against blowing out on commercial, right? And there are various incentives you can put in it to try and align what you're trying to do as a state. Another component is an opportunity to try and move some of the money, like we're talking to where we want it to go.
But it could be contentious initially.
Where you take it from usually.
So, right, well, having everyone at the table for that discussion is so important.
I think one of the things I appreciate the most is the partnership between the Green Mountain Care Board and the agency to get that feedback and leveraging our different opportunities to do that, whether it's agency facilitating the Green Mountain Care Board, the healthcare reform group, work group, or us being able to bring things to the Green Mountain Care Board's public meetings to be able to elicit real public feedback. And I think there are different ways to do it, and we really worked hard, both in the selection of a model and in the selection of the global budget methodology to work back and forth together to make sure that it's well informed by a broad set of constituents.
I have a question. Obviously, Act 167 is a significant piece of legislation, but part of the reason committee chairs are here is whether there needs to be legislative action and modifications. So as you're looking and the experience to date, are there ways, do we need to sort of recalibrate? Do we need to perhaps make modifications? And I'm not going to worry about it so much, but other people will. Do you think that we are at a point where we need to sort of do Act 167 2.0, for example? I don't know if that.
Okay, it's really interesting. I asked Senator Lyons that the other day, just in fact, not to out you.
She didn't program me. She didn't pay me. But obviously, as you gain experience and feedback and whatever, you say that sounded good. at the time it was passed, but we need to make some changes. So I was just thinking.
So that's an excellent question. I'm sure there are folks in this room as well as outside who would like to make huge changes to the process, but having very specific recommendations is something that we will look for. First, we're just getting started with this, but and as we go forward, we might see that there are regulatory gaps that we need to discuss and fix, and we've already identified some of those. And those are difficult to work on. We're also looking at the whole funding issue, so who's in charge of what, when, where, how, that becomes a critical discussion that we may have to have.
As well as a timeline, I think is really
Yeah.
important.
Good point.
I think that goes really well into the Oliver Wyman. So if we go to, we started kind of because the legislation did it in terms of how we pay, but when I think about it, I think about changing the system. We need to decide what is it that we want and how do we support the change? You'll hear us talk about that as transformation. How do we know through our data and measurement? And then what is it that we need to do from a payment standpoint? We started with payment. We started with some of the clinical things that we've been doing because they're interrelated. I think what the Oliver Wyman report did, and Chair Foster will go through that and we'll begin to touch on what the recommendations were coming out of it, is help us decide how it is that we need to transform. And then I'll talk about what are some of the supports that we need to do that. And there's those three parts in my mind, to helping support transformation. And then there's the regulatory component too, that also is a key driver. And so I think that goes to us deciding how we want this work to happen across those 4 buckets. But I wonder, Chair Foster, if you can go through kind of where the Oliver Wyman report brought us, but that really helped us to define what are some opportunities for change. We identified some in sustainability. We've driven them because we couldn't wait, but it also reinforced that many of those were the right things to do and that there's more for us to do, particularly as we think about our hospital space and some of our others. But I wonder if you can.
Sure. So I'll just briefly touch on it because some of it's now history and we're now going to the next steps. The Oliver Wyman project was about a year-long engagement looking intensely at our healthcare data and utilization and trends in utilization, demographics, and then also a qualitative component with a huge array of meetings with all kinds of stakeholders across the entire state. One of my favorite aspects was actually going to the community meetings throughout the entire state, Springfield, Middlebury, St. Albans, Newport, Burlington, and it was wonderful to hear the feedback from the community. And that was really an important component to informing the recommendations. The recommendations came out, I believe, it was around September 19th or so, I think. Is that right? Yeah. We were in the middle of hospital budgets and then that was also out. And the Oliver Wyman recommendations, they were called 4 categories, really. There were some recommendations for the legislature, some recommendations for the agency, and some recommendations for the Green Mountain Care Board. And then there was a set of recommendations for changing the hospital system as a state. So we have 14 hospitals plus the retreat. And there's expense to overhead and operations, service lines. And if you can't staff things, it gets even more expensive and challenging. So one of the big takeaways from the hospital side for the Oliver Wyman report was creating centers of excellence for particular practices. And they looked at volumes of care and was there sufficient volumes to justify a practice in an area? Is there a safe way to do it elsewhere to combine care? Similar to what you're discussing in the school conversation, very, very related. And I'll go briefly to the recommendations for the legislature, AHS, and the care board. And I'll speak a little to these and I'll turn it over to the secretary for her views. And then after the Oliver Wyman report, so the care board led Oliver Wyman report process. I will point out it was an entirely independent report. And my goal was to be able to stand here today and say that we did not influence what it said. I didn't want any influence on it. I wanted to be independent. I wanted him to tell us and their team to tell us the truth. And I didn't want to be political. It is what it is, and this is what you're being told. In fact, I told him, if you have recommendations that I won't like as the chair of the care board, put them in. And he did. So in any event, it's just important to recognize that there's, I don't know how many recommendations, 150 pages or so with a lot of recommendations in there. No person is going to like all of them, right? So, I hear a lot of feedback, oh, this is wrong, this is wrong. I agree. Some stuff's wrong, but this is the menu of options that we have as a state that was presented to us to consider. So after the report comes out that we led working with the agency, it then transitions through Act 51, and the agency will lead the transformation work with our healthcare system, and we will support and help as they did with us. So before we turn to that piece, I will go over the recommendations. These are from the Oliver Wyman slides, slide 32 of Oliver Wyman and slide 16 of my factor, whatever. Okay, I keep gonna. Yeah. Real briefly, I'll go through the 6 recommendations that were priority regulatory changes for the Green Mountain Care Board to apply starting in 2025. And I will just tell you where I see them. Keep in mind, I am 1 board member. We are a 5-member board. No action happens regulatory substantive front without 3 votes. And sometimes my vote is not the one that goes forward. So I'm speaking as 1 board member. The first one is permit no further increases in commercial subsidization for hospital financial shortfalls. I agree with this. We do not have the commercial market or the resources for our ratepayers to continue to pay really, really high commercial rate increases. We simply don't. So I agree with that in theory and direction. Number 2 is refrain from licensing any further hospital-based outpatient department unit. I think the theory behind that is that hospital-based outpatient departments are more expensive than other providers providing that service. I do not entirely agree with recommendation number 2. And I do not agree with it entirely because I think that many hospitals can provide outpatient department units in a cost-effective way. The UVM Surgery Center was one that we recently approved in the CON. We put a condition on it that the commercial costs could not be more than 170% of Medicare. That's delayed for financial reasons, but if they were able to do that at 170% of Medicare, I think it would be a positive. I don't think it's necessarily binary that it's more expensive at a hospital. You can do it in a way that is cost effective. So I agree with the sentiment and theory behind it, but I do not agree with it as a binary proposal. Number 3 is an important one. Simplify and shorten the CON process. I wholeheartedly agree with this. I would like to exempt many, many components of the CON program. Replacement equipment, that kind of thing. I do not think.
Yeah.
Yes, I'm sorry. Yes. So I think that there's a lot of resources from the board that's put into this work, and there's a lot of burden put on providers to do all this work. It's an incredibly intensive regulatory process. I think we can simplify significantly. It does also chill competition. If people have to go through the CON process and expend millions and millions of dollars, it sort of tightens a threshold of who can do it, right? And when we saw the Green Mountain Surgery Center come online, we saw a very combative, very difficult, very expensive process that in hindsight never should have been that way. But it's been a boon to the state to have Green Mountain Surgery Center providing the services that we need at a very accessible, high quality, affordable price. So I do think that there's a logic to increasing the thresholds and simplifying the process. Where exactly you are, all kinds of states have different thresholds. Encourage freestanding diagnostic ambulatory surgical centers and birthing centers. Agreed. We need more cost-effective providers in the state. Hospitals are very good at many, many services, but in our state, we've come to rely on them, I think, too much for our care delivery system, and that creates expense. And that might be because they're filling the gap, but we need to consider whether or not there's a different way to do it because we can't sustain the expenses. And hospitals have stepped up to provide some of the care, but is there a way to make sure they can do it cost effectively, or is there opportunity for others to fill some of those needs? And it's a balance there. Number 5, begin movement to reference-based pricing, ideally at 200% of Medicare or less for PPS hospitals. In sentiment and direction, I agree with the reference-based pricing notion in number 5. I think 200% of Medicare would be too disruptive for our hospital system at this time. To give you a sense, national average for hospitals is probably climbed up to about 250% of Medicare. Our PPS hospitals, I want to be incorrect, but I think most, if not all, are above 300%. So very, very, very,
What is PPS?
oh, sorry, prospective payment system hospital. That's distinguished from a critical access hospital.
So medium-sized hospitals.
Okay.
Like Rutland, Central Vermont.
I have a reference-based pricing question. Should I wait until later in the meeting?
Do it now, if it's related to the presentation, but if it's basic to reference-based
I
pricing,
think it's related to the,
ask us, and we'll see. Yeah.
I'm having trouble. I know very little about what we're talking about at this table, but I am having trouble seeing reference-based pricing makes sense to me. The ahead model and global budgeting makes sense to me. Having them integrate makes very little sense to me, and I wonder if maybe you all who have thought about that more could tell me about that.
So this is a good question later, isn't it?
Yeah, we have, we cover it later.
Can't wait.
And Senator Lyons, one of the recommendations that we had in a smaller group that is meeting is potentially to bring in Milbank Foundation and the National Association of State Health Policy Leaders to talk about how the two of them come together. And generally, one of the things that we've done with AHEAD has been able to negotiate significant return of investments. Whether it's enough or not, we'll debate, we can talk about in the AHEAD section. Significant investments from Medicare back into the state, but commercial rates need to be set under a hospital global budget. And one of the ways to set commercial rates in a hospital global budget is to set them based on reference-based pricing. And reference-based pricing, just so everyone in the room is on the same page, essentially means that you take Medicare and you say, this is how much Medicare pays, and then you set a percentage of that for the other insurers. We do it significantly in Medicaid already. And we've been doing that for several years, where we say for each line item, and that's the difference. You could set a flat rate and say for everything, it's at 200%, or you could say for different line items that you want to prioritize, you could set them at a higher or lower rate. And that's what we did in Medicaid, whereas primary care is at a higher rate and hospital is as for some services at a lower
But
rate.
it comes with some drawbacks, because as Medicare rates decrease,
Correct.
so does the other.
Yeah.
Correct. And so there are what I'm good in ways that we can do global budgets. And so we'll come back to reference-based pricing.
And I can wait,
That's one
thank
way to do it.
Yeah, I think we should. And what I was going to say is I did ask for some clarity on this, and we'll do it. I've asked for it a little bit later in the meeting. But I would like to share with all of you that I'm looking forward in the beginning of the session to have, as Secretary Samuelson said, some national experts who can come in and give us a very concrete and clear presentation on not just reference-based pricing, but all other options, so that we can understand the implications for us in here. And it's a great question, an absolutely perfect question.
Sorry.
Question?
No,
Oh,
side
all right,
conversation.
good. No.
I think
You should
we're
put the
just trying
budget
to
people
reminisce
together
the
about
budget,
how much money we put
because
in
we
where.
did something with BSEA's request on reference. pricing.
We did, we asked for
Yeah, and we're funding
A report,
Yeah.
the report. You know, and so that's one of
I'm
the
just
questions.
saying that's another piece here.
A huge piece.
Simultaneously.
Exactly.
And then think about it, we will have to think about it together, but if you have one group doing this and another group doing that, and it's not by service, it's by group, insurance coverage, you know, we're looking for alignment somewhere along here.
So that's why I bring it up.
Yeah, I'm glad you brought it up.
Uncanny at how many reports that you anticipated align with the work that we're asking for now. And
Love that
reference-based pricing.
validation. Love that validation.
Yeah, reference-based pricing is one of them. EMF, which I'll cover in a second, is another.
Senator Westman.
Just ask what the timetable is for all of this now.
For,
How do you envision this coming together and what's the timetable?
okay, so
Yes. Can I make a suggestion? Can I make a suggestion? Answer that question briefly, and then let's keep going through the recommendations.
I was gonna suggest that we, for the time that it's multifaceted and for what we do next with the Oliver Wyman report, It's the next section of the presentation.
But that's fine. I would just say to you, all the stuff you're talking about and the realignment that's, you're talking about. If this takes 6 months, in my community, we're going to lose services. And, quite frankly, I'm probably 25 minutes early on this. My hospital is handing over, money to my FQHC to keep it in business. And the announcement's coming out in a letter at noontime today. So I'm listening and I'm talking about global budgets. I'm just hoping that the work that's going on already in the communities that's ahead of you gets recognized.
Right, and it does.
And I would say to you that we can't do this all in Medicaid rate increases, but in certain areas, you've got to have.
So one point I would make, I fully agree with the senator. These things like reference-based pricing, global, they are hard. They are complex. They take years to work, or you got to make them, it takes time. So yes, there is an urgency that is not lost on anyone in this, I think anyone in this room. And these.
We will have less services in my community in the next 6 months if we don't.
Local clinic was 600 over in Mad River Valley, 600 people on the waiting list.
Yeah, consolidated into, and I think that's the challenge that we're faced, is that similar to the education system, we don't have enough workforce. And that's the Mad River, like they don't have enough providers to keep that tight. So they are consolidating into a footprint that's like 8 miles away. The same thing is likely to happen in Lamoille. I hate to see it happen. And yet, in some cases, whether it is a reduction in access or a restructuring is a big question. And I think in both cases, it is a restructuring.
I have a question about moving to your number 6 there. When we talk about all hospitals, I live in Brattleboro, but it's going to represent like a lot of that whole eastern southern corner of the state in my question. We use the Dartmouth Hitchcock medical system. Sometimes we use the full Massachusetts healthcare system. We use very little of sort of the rest of the state system in really a whole region of the state. And when we were talking about all hospitals, it would just be helpful for me throughout the presentation to have some sense of how that fits in, right? They're not part of the report in a meaningful way. My billing always gets messed up from Dartmouth because they don't follow, my mammograms always get billed, even though mammograms are free in Vermont, right? It's even little stuff. There's a big disconnect between the two states.
Yeah, I'll finish on 5 real quick and I'll answer that. That's okay. So on 5, the reference-based pricing thing. What we're seeing in the Blue Cross side and the expense side for commercial insurance is when your prices are really high and you're in a utilization spike, you have crazy money. So reference-based pricing is a tool to deal with reducing the price as volume goes up, because at the end of the day, you got to pay that number. So that's the tool that is there. Like I said, I think the recommendation is too aggressive and too fast for our state at this time. It'd be too disruptive. I view it as more balanced and maybe judicious and careful, because any reduction commercial rate has consequences to the private system. In terms of recommendation number 6, the theory behind that was not really EMR is a separate thing and billing's a separate thing. The point here is more in the hospital budget process to have hospitals allocate and define where they put money and how they move it.
Common chart of accounts.
Oh,
about
exactly.
education. I would really love if we could stop talking about education throughout the year. But, and I just mean as one example, when you say all hospitals, that does not include Dartmouth, correct?
We have no regulatory authority.
None. Okay, great.
Great. I'll stop there and turn to the secretary. Thank you.
But on number 6, alignment of auditors and financial.
It creates a much more level and fair playing field and understanding of apples to apples across various hospitals. You don't want a hospital to have a budgetary decision that's based on a fluke of how they define something.
Of all of those that you have just listed, which of those will be the least complex to do, because they will require legislation? Which is the low hanging fruit? That's the question.
Some we can do within our existing authorities and we can do on our own as currently, but I would say number 3 and number 6.
Thank you.
Speaking specifically to the Agency of Human Services recommendation 1 is removing, sorry, we were looking at the legislative ones first,
You
so that's okay, I got it. Regionalizing specialization of services across hospitals and healthcare systems. We are beginning well, we'll talk about in the transformation section, is that we are working on getting a contractor and who can work with each one of the hospitals. In the meantime, we have been working with some of the hospitals to look at some of the recommendations that Oliver Wyman made. So for example, OBGYN in Central Vermont was a common one. So convening those hospitals to talk about what does regionalization make sense? First of all, that's the impact, feasibility, and financial, the finances of it. But that's just one example. Another one would be in conversations with some of the hospitals related to the decisions around dialysis. But we do think that this recommendation makes sense. We know that alone, we're not going to be able to do it on our own. And so we're really looking for a contractor who has the expertise in hospital finance, quality improvement, and clinical medicine to continue the work of Oliver Wyman. EMS professionalization and regionalization. You all had a lot of foresight. You asked the agency to look at this already. We are in the process of doing that assessment and preparing a report for the legislature. Improving access to care coordination and care management. You saw the list of things that we've been working on. I think that many of those hit on this. We also are engaging in the work under Act 119 from last year, which is really to look internally about how we can improve coordination. And it's been a priority of the agency for a while, but how we can take a more forward-facing approach to improving coordination, particularly for those who are complex. Dual eligibility dual eligible targeting, planning, and coordination. This is one we would need to think carefully about. There's a lot of work that's happened in this area in the past. It's probably not the first area that we as an agency would prioritize, given the other pieces that we have in front of us, and that this is a very small subset of the broader Oliver Wyman recommendations. We might prioritize looking at some of the other areas like the mental health and substance use recommendations, transportation, long-term care before we go.
And some of those people are captured in number 3 as well.
Correct. And then statewide electronic medical records. This one we were excited to see come forward. We've been around in Vermont for a long time. We discussed this before, the implementation of electronic health records. The HIE program is looking at this. And we heard when we went around to the hospitals and to the communities, this was one of the things that several of the hospitals were eager at exploring. But this will be something that will take time. Many of them have electronic health records that they adore and love, but others are at the point of transition, and trying to get to support for statewide EHR is something that we would look at carefully. I think from there, it makes sense for us to move into the legislative recommendations.
Can I ask the same question that I asked Chair Foster, and that is of the 5 that you've listed there, there will be some things that might require either legislation or significant or other resources. Which are the low hanging fruit?
I think the low hanging fruit in some of the areas that we've already started to look at are the EMS. I think through our hospital transformation, looking at what services are necessary at the state, regional, and local level. And you'll hear that as a theme across not just the hospitals, but all of our providers. Is the other area that I would focus on. And then number 5, the electronic health record.
Thank you.
And beyond that, I think you'll see us making proposals in other areas to strengthen the system that are related to the other recommendations that Oliver Wyman had which align closely with the work that we do in disability and with the broader, and you're right, Sarah. Go. And with the broader parts of the agency in terms of mental health, substance use, long-term care. And, you know, we've touched on most of those at this point.
You mentioned a contractor who will be working, in particular on number one. Can you talk a little bit about that process?
Yeah. So Act 51 directed the Agency of Human Services to drive transformation coming out of Act 167 stakeholder engagement. What we are planning to do is to continue with the stabilization work, which I outlined above. We're working on the emergency medical systems report, trying to move that even earlier than it was originally projected so that we have a plan there. For hospital transformation, we are looking at identifying a contractor who can come in and work with each one of the hospitals to take the plans to take the Oliver Wyman recommendations and assess for their local area which of those recommendations made sense, and to create a plan that aligns with the HEAD in terms of the fact that will be a requirement in the HEAD model. And through that, we will be looking at the regionalization of services. We are in the last stages of getting that contractor on board to help augment the resources that the agency has. Again, a plan is a plan is a plan. I've heard a lot of folks say, well, we have plans already for community health needs assessment and others. In this case, we're really going to be taking a more quality improvement focus, which is, you know, I don't just want another plan. I want you to take the specific measures that are in the Oliver Wyman report, or specific measures a hospital has identified, or specific measures from the data that we covered today, and actually begin to drive changes. Again, that might result in some of the things that you've already seen hospitals and healthcare systems do, but we're hoping will happen in a very rational way where we can look across the health system.
But it sounds like it's driven more at a local level with hospitals and community needs.
Correct.
Rather than.
It will be driven at I think it's an and both.
Right.
I want to be really clear.
Sure.
At the local level, we're going to need to be able to determine what makes sense. And a few of the things that we're doing in that too, the recommendations from Oliver Wyman also talked about transitioning hospitals over to emergency rural hospitals. We've engaged HRSA, who determines which hospitals are critical access hospitals, because all of those hospitals are critical access hospitals. They also determine which hospitals are best suited for the rural emergency hospital status at HRSA. They have a program where that's what that HRSA is. Healthcare.
No, I understand HRSA. Define what this hospital reference you're talking about. What distinguishes it from critical access?
Yeah. So this is where I'm not an expert.
Oh.
Okay, but a critical access hospital meets the community. They're rural hospitals with that are geographic.
I know what it's, but that's new rural entity.
Rural
emergency.
Rural emergency hospitals, what we are investigating at this point. But
It's
what the main
basic.
focus is serving the emergency medical needs of a community versus the broader piece. We need the expertise to do that assessment, and HRSA has a team that comes into critical access hospitals and does an assessment to determine which is more feasible for the community and for the hospital's financial stability. And so that for us, that's one of the options, in addition to having a contractor working with them to tap into the experts at the federal level that do those assessments.
Secretary, I have a question. So I appreciate and value it has to be done at a community level, but yet I haven't heard, and maybe I missed it, how we're going to look at this statewide also. Because we can't just say we're going to make changes here and to that balloon effect, right? Not know what they're going to make, how they're going to do it there. So what's the overall?
That's the value of having one contractor who is working with all of the hospitals in the state, because the Oliver Wyman report also had recommendations for regionalization of services. So they will pick up that work. some of the things that we've, as I said, that we've already done is take some of those recommendations, start convening hospitals. We have to be very careful around those hospital conversations because of the laws that promote the competition between hospitals. So one of the things I want to acknowledge is we're at a place in which we have to have a critical sense of urgency. And at the same time, we have to do this thoughtfully and carefully and with a level of expertise that we are building here in Vermont.
One comment on that. Anytime you change, if we're talking about specializing in centers of excellence, you're going to be removing services at particular places. That's, no one's gonna like that. Locally, they will not like it, and I do not disagree with them.
Absolutely.
But there's context that is important in thinking about this. If we focus on the removal, but not the other two pieces of the coin, one is we're also talking about adding services. We have so many gaps in primary care and mental health care. You can't have it all and pay for it all. So you have to think about, can you afford it? What happens? How are you gonna pay for it if you don't make changes? Then two, what are you losing if you don't? And that's sort of the rubric, those three components together, not just losing, also adding, and also making sure you don't lose it. Because this isn't like an Oliver Wyman report. This is a national problem. This is an economic problem. This whole effort that people are really pouring their life and career into is to make sure we don't lose the services we need that we have. That's the goal.
Just human emotion sometimes make it.
A bit of passion in there.
There is a lot of passion in there.
Yeah.
Secretary and I avoid it.
Nobody loves a regulator, we know that.
To give ourselves a sense of optimism, because it sounds like this is all planning for the future, I think one of the things that's helpful is to know what are some of the hospitals doing. Now, I will note that these are some of our medium-sized and smaller hospitals, and everyone asks, well, what's going to happen with the bigger hospitals? And having met with Blue Cross Blue Shield yesterday around their data and Medicaid yesterday around their data, and having talked with Dr. Epen this morning, we really are talking about convening folks to really look at and dig into that data imminently. But for a couple of our smaller hospitals and our medium-sized hospitals coming out, here are some examples of what we're already seeing for this work. We're seeing Gifford Hospital engage in the transfer center at UVM and Dartmouth. That means they're taking patients back out of those academic medical centers to a smaller hospital where they can get appropriate care and care at a lower cost. Particularly in this case, particularly with Dartmouth, the work with UVM is just starting. We're seeing them undertake initiatives consistent with the Oliver Wyman report to assess and increase provider productivity. They are already seeing significant increases in provider productivity from the work that they're doing. They're participating in conversations about the regionalization of OBGYN. And they've, I know everyone talks about the loss, but what do we gain? Here we are going to talk about a loss, but what we gain is the sustainability potentially of this hospital and an increase in access in the areas where they've increased their productivity. And so the loss here are two service lines that they weren't doing enough business in, urogynecology and chiropractic services. This is what we're talking about when we talk about transformation plans, transformation planning.
I just want to, I'm actually going to compare this to the school system, even though I begged for that not to happen today, because this feels like a great synagogue. But I think it's, when you talk about sort of what we gain, I think it's really important to be highlighting that when the full system gains something, everyone in that system gains something. So yes, it's like maybe access to improved services when you do travel a little bit further. But I think on a global level, it's also really important for people to be keeping in mind that this is all part of stabilizing a financial picture.
Yes.
Right. And that in some ideal universe, everyone's premiums would also stabilize, right? Or their copays, whatever it is. So I think it's really important that we keep an eye on the global picture when we're talking to people about what change might mean for them personally.
Yeah, I think that that's absolutely right. I'm glad that you brought that up. The two primary care examples are true to my heart for that. Folks are going to have to drive a little bit further, but those organizations might gain some financial stability without reducing the access that they already had, because they're not reducing providers. but they're just making it more efficient. So you're absolutely right. What are our goals here? In Rutland, it's, they are looking at considering options for dialysis. As UVM moves out of that space, whether they can or should pick up on that. And they're working with both the board and the agency to look at that from different lenses. For outpatient, that's for outpatient. They're also in conversations with the home health agency about what home dialysis looks like. So what are the new innovations on the front to make this easier? And this first bullet and the second bullet are connected. They are, because they've been able to reduce the number of individuals who are boarding in their med-surg beds, they've returned their beds for ICU, which have been with med-surg patients, to actually now being able to do intensive care. And so they're looking at being able to regionally, this goes to that regional conversation, be that medium-sized hospital that brings patients into an ICU. And this is where the regional conversation happens. In order to do that, they need to be able to do inpatient dialysis because that's a significant portion of their ICU. So you're seeing them begin to think about, you're seeing the net outcome of the efforts that we've already done, like eye care, move people through the system. And that's why it's incredibly valuable. And you're seeing the hospitals then say, okay, now what can we do next? It's that balloon squeezing. We actually solved a problem in one area, and it's allowing us to solve a problem in another area.
And I want to ask a question because you brought up the dialysis issue, which really the loss of that service was a result of the regulatory budget process. And you're talking about 167. I want some clarity on that budget decisions are not going to be driving 167 decisions. And I see it critically important to keep those separate. But I just want to hear your thoughts on that. And I'm looking at the regulator in this case.
We have no plans to change our regulatory process. We're starting to work on guidance for fiscal year 26 now. That will be out and finalized in March. There's a very integrated process between the HCA, the hospitals, and the regulator in formulating that guidance. The care board will not be making service line specific decisions in its budget process. We'll do it consistent with how we've done in the past. That doesn't mean that any budget that gets put before us will be approved. And that doesn't mean that we're driving transformation through our budgetary decisions. It'll be consistent. But I would expect going forward on the hospital budget side is that we will be very mindful of the ability of Vermonters to pay for it and recognize that there can be disruptions in the healthcare services when all of the money requested isn't provided. That's just the nature of the work of what you're trying to balance. And then that third prong of all the other providers in the system. If you have $400 million here, does the FQHC get $1? And that will be something we're focusing on in our regulatory process is the system. But no, the short answer is we will not be making service line recommendation decisions from all of alignment in the budget process at all. We don't have the capacity to do that. And I don't have any interest in doing that. It's in there.
Thank you. That's helpful. Thank you.
But I think it's an astute observation that they have an impact on each other.
Right. Yeah.
In this case, in order for Rutland to take on dialysis, one of their critical questions about whether that's feasible is whether they actually have the revenue in the regulatory process. And that is where they need to work with the Green Mountain Care Board to determine that. So in the process, rather than just shutting things off, what's it look like to turn things on? And that's, I think that we cannot ignore the fact that those two things are interlinked with each other. Okay. So
Are we going to go through the last list on the legislatures?
Why don't we go up to one slide down from this?
Okay.
And then we'll go, then we'll go there. So, and this is one that, that Chair Foster and I go back and forth a little bit on. But as we took a look at the legislative recommendations, now I want to note These are what Oliver Wyman identified as this year's priorities legislative recommendations. I also want to note that the report was over 150 pages, not really a report, the slide deck was over 150 pages long with recommendations that go far beyond these things, and yet were considered by Oliver Wyman, and we would consider as an agency them to be high priority. So I don't think that the legislative asks that we have coming this year will be solely focused on just these things. I mean, I've already identified that substance use is an area where we're doing gaps assessments right now. I don't know how far we will get in terms of our proposals. That's part of the policy and budget process. But that's an area that we as an agency would focus on, and that is specific to the Oliver Wyman report. That said, removing barriers for building affordable housing for residents and newcomers to the state. I think in this case, where it's the work that we are doing closely with the legislature last year, and that we all know will continue this year, on how we can identify any of the state level recommendations that will help to catalyze housing in all areas, because it's critical to healthcare, both for workforce housing and to address the overall health related social needs for Vermonters. And I think that proposals are coming from ACCD, from the Agency of Commerce and Community Development.
We all know that one.
I figured. I just want to make sure everyone in the room will be coming from ACCD related to that for what we can do at the state and the local level. I don't think any of us want to go into the housing rabbit hole as much as we don't want to go in the education rabbit hole today. I've mentioned that we are in the process of evaluating the EMS. You've asked for a report. That report will come to you. We're again, this is another agency outside of AHS or the Green Mountain Care Board, but we are making significant progress on the expansion of cell phone coverage and telehealth to rural areas of Vermont through the executive branch of government. We're in the process of conducting analysis in accordance with Act 119. The initial report on that on what our plan is to engage stakeholders will come in February, and then later in the year we will propose more thorough recommendations, but that's an ongoing priority for the agency. And I just want to make sure that folks are really clear about that, and will continue to be a priority. Related to the recommendations for developing a statewide regulation provision for emergency hospitals, I talked about that already in terms of our work with HRSA to really better understand. This is where we need to pull in our federal resources, really understand that. And expanding professional licensure and practices of scopes for nurses, EMTs, and other professionals. That's work that we are just starting, and I think the legislature can just start but is related to the Office of Professional Regulation. Those are things like, what do our pharmacists do? And can we use things like test to treat, which we did during the pandemic to help alleviate the pressures in primary care. So this is a really exciting area, but I'm not sure that beyond what I think that this is going to take a little while to grow and to develop.
It may not be just scope of practice. It also has to do a number of years ago with so much education being done online. There was a rural nursing board had that all the teaching faculty had to be licensed in Vermont. Yes. And if you've got a university in California and students in all 50 states, they're not licensing. And so there are actual regulations that probably need to be modernized as well. That one did get changed, but it raises the question, are there others that would actually be outdated in terms of how people get their educational credential?
Exactly. And that's why we're trying to work really hard to bring the other agencies up to speed, whether it's other departments within the Agency of Human Services or AOT related to transportation, or ACCD based on housing, or the public service department related to broadband. It's going to take some time to bring up those, but I think what we've seen is so far that there's some consistency of directionality. And so we'll continue to work on this.
So you didn't name the secretary, the OPR at the Secretary of State's office, and I assume it was just.
Yes.
Okay.
Just an oversight.
Questions, or we're gonna keep going, or how are we doing?
We're at lunch.
No, we're at lunch. I just want to make sure that questions have been asked and answered, and you've had an opportunity for, in particular, 167, because we're going to move after lunch to understand the ahead and the payment on a little bit.
I think the one thing that didn't come up is what folks mentioned earlier today, which is Oliver Wyman did recommend that we more clearly define roles and responsibilities. Because, we think about a single regulator, but the fact of the matter is healthcare regulation is covered across a host of agencies and departments, whether it's the Agency of Human Services for role and responsibility to assess our mental health needs, our substance use needs, our long-term care, yada, yada, or whether it's DFR's responsibilities related to health insurer solvency, or the Green Mountain Care Board's responsibilities with hospital and insurer rates. Being able to help, like good fences make good neighbors is what I've often heard. And so that was one of the things that was recommended. I do think that there is value there. I don't think that there's one single agency that can do this work alone. And so when I look at the Oliver Wyman recommendations, I think that there's value in us considering what collaboration looks like going forward, what governance looks like, but also that healthcare reform legislation is like an old farmhouse. I think, Senator Kitchell, this was your actual analogy to me probably about 5 years ago, where we've done legislation upon legislation, but we've never talked about taking down the walls between the rooms in the farmhouse. And I think that's one of the recommendations Oliver Wyman has.
Senator West.
I just say that if communities are beginning to take down those walls and services are being offered in a way that are more
Exactly.
cohesive within the community, you're behind the 8 ball if that's already happening. in the community.
I think what Oliver Wyman's recommendation is that that there is legislation that doesn't that has conflicts in it that are not that define the same role among multiple different agencies, and or leaves gaps. And so that was one of the things that they highlighted was an opportunity to take a step back and look at that. So that's not my recommendation.
I'm just
We are
saying,
working very hard. to
In
figure
a-
out
Administrative and
collaborate.
jurisdictional clarity
Is helpful.
So you bring to mind a bill that nobody liked not last session, maybe the session before, where I tried to get that conversation going, and now I think it's being put on the table again. I think it's a great conversation. How do we coordinate all the regulatory roles that you folks represent? I mean, you represent regulation in different ways. We also have a PR. It is a great conversation, and so there may be something that we can do to build some collaboration and some linkages, remove the silos. I don't know how to do it. It's not, but it's something we should probably talk about.
And we're doing it culturally. I do want to reinforce that. We're trying to, and I think that, that was the imperative, and I wholeheartedly agree with you from the beginning, which is there's been a trust erosion over the last few years because when systems are in crisis, they come out swinging.
Yeah.
And we need to be able to collaborate while also trying to move through the crisis that we have in front of us.
That is a really good place to say, we're going off live
and go to lunch.